All right, welcome to part two of module one, the elimination concept lecture for you. At this time, we're going to go ahead and leave off with diagnostic testing because that is where we stopped at in part one. Um, and again, in order to not make this information look so overwhelming, you got to think of a concept as a whole piece. So the things that we're going over in the lesson content have to do with what will be generally found under the elimination concept. Obviously, you're going to have to pick together and piece together what might be appropriate for what condition, what medicines might be appropriate for what condition, but you do have to think of the concept as a whole so it does not seem as overwhelming as trying to learn 50,000 conditions. So as we're going over diagnostic tests, as we're going over medications, you got to think of it as, okay, this is probably appropriate for this condition and I'm going to apply it in that area. Um, and yes, I do usually talk about certain conditions throughout. Some of the more common conditions like kidney stones, UTI. Clearly, that's going to be some of the conditions you need to be a little bit keen on, a little bit more keen on, because you're probably going to see it fairly often. And that's how you build your experience. You build your experience based on repetition. And the more you take care of a UTI patient, the more you're going to know what to expect from a physician, the more you're going to know what expected outcomes should be based on your interventions. So yeah, just kind of start taking everything under an umbrella and then to help with your critical thinking, piece together what might be appropriate for what. So moving on to lab testing, you have a few lab tests underneath that are appropriate for several different conditions. For instance, urinalysis. What are we finding in a urinalysis? This is pretty much an analysis of certain substances that are in the urine that should probably not be in the urine, or if it is in the urine, how much of it is in the urine. Typically don't want to see white blood cells in the urine, typically don't want to see blood in the urine. Um, Also, when we start talking about diabetes, ketones, and things like that, these are things that can definitely be tracked if you do a urinalysis. Um, Renal function test, huge when you're talking about kidney injury, acute kidney injury, or chronic kidney injury. Used to be called chronic renal failure or acute renal failure. Reasons why people need dialysis because their kidneys just do not work. Um, I would definitely be familiar with the normal ranges of all of these labs because you will be approached with certain questions that have to do with what should be addressed with the physician. And clearly, if there's four options, three options are all normal, but you're seeing that abnormal, then that's probably the one you want to go with. That's probably the one that you definitely need to address with the physician so you can see what interventions are going to be appropriate. The creatinine clearance pharmacy uses that a lot. There are a lot of medications that can definitely harm your kidneys, and creatinine clearance is just an inside view of how well your kidneys will possibly tolerate something. So pharmacy looks at that with dosaging and the frequency of dosages of a lot of medications, particularly your antibiotics or some of them as well, that you just have to be careful so you're not making the patient toxic. Cultures are appropriate for urine issues and for GI issues. So for GU and GI issues. In regards to your PowerPoint, mentioned the UTI, how UTI mainly is caused by about 90% caused by E. coli. That's something that can be followed in that culture. On the other hand, if you have a patient who has issues with the GI system, bowel irregularity, maybe diarrhea, they're definitely going to want a culture to see what bug might be present. That's definitely how we find C. diff or C. difficile so that we know that we need to treat it with certain medications. A cold blood, um, you see it ordered when the patient's hemoglobin has dropped, and we obviously see nowhere where this patient is losing blood. So then we start thinking internally, are they losing blood from the GI system? They just not have mentioned anything about what their bowel characteristics, bowel movement characteristics look like. A cold blood will definitely be ordered so that we can figure out whether or not they're bleeding through their bowels. Biopsy appropriate. for the assumption that cancer might be present. Again, we're just looking at tissue formation and abnormalities and the possibility of anything being metastasized. Colon cancers, bladder cancers, definitely would have to go through the initial part just to recognize whether there is disease tissue or not. There's plenty of scans and imaging that we can do. You can do the KUB more so for possibly kidney stones. Because again, look what's being found in the KUB. What is it looking at? It's looking at the kidneys, ureters, and the bladder. So if you're thinking about things that have to do with the bladder, like bladder cancer, looking for tumors, renal stones, etc., that would be very appropriate. CT scans, MRIs, ultrasounds, also extremely important when we're thinking about possible bowel obstructions, ileus. And the angiography is pretty pertinent with we're thinking about how, especially if we're thinking about kidney failure. So how's the blood flow in the kidney? Is it not circulating correctly? That angiography definitely helps with the more specific flow of blood versus the more gross image that we might get in a CT scan. The angiography is a little bit more specific and a cleaner picture per se. We can definitely do scoping. When you think about colonoscopies, I would think about the basics of colonoscopies. Why would someone have a colonoscopy ordered? Why would someone have an endoscopy ordered? Colonoscopy is through the rectum, endoscopy is through the throat. And I would think about the pre-procedure, during the seizure, so the procedure, so what's happening, and post-procedure. So what's happening throughout this entire process that we're prepping somebody for colonoscopy. What age groups might be appropriate just for preventive screening. It is currently recommended that those 50 and over have a colonoscopy every 5 years. If you have colon cancer in your family, rectal cancer in your family, they may very well want you to come in earlier than 50 years old so they can kind of get a handle on things before anything bad were to happen. Post-void residual, we do that not fairly often, but often enough that at least I know what it is, where we have a concern about the bladder not emptying completely. Therefore, we do a bladder scan after every void, and we document how much is left in that bladder. So are they completely emptying? If we initially bladder scanned and it was 500 mils in there, and then they urinated and it still was about 300 in there, that might be cause for concern to intervene because we're possibly thinking urinary retention. Catheterization, whether it be a straight cath or a Foley catheter, could be appropriate for your patient. And any additional urine flow studies. 24-hour urine is appropriate in certain conditions. You can kind of connect those with other conditions that we'll definitely be talking about in the future. For instance, with identifying ketones and the amount of it, proteins, etc., with diabetes. All right, so intervention wise, what are we doing? So if we're following the ADPI or the nursing process, what are we doing? We've been able to assess our patient. So we got some subjective and objective data about our patient. Subjective wise, they've told us about their diet. They told us about maybe going on a trip to Mexico and they ate from the food bar and the salad bar, and all of a sudden they started having some issues. Subjective, remember, is what the patient's telling us when the initial complaint started, how long it's been happening, where at in the stomach that they're feeling certain pains or discomforts, and then our objective data is again going to be our assessment piece, our hands-on assessment piece. In regards to diagnosing, think back to what I mentioned about constipation. Constipation can definitely cause acute pain, discomfort. So with those nursing diagnoses, we now have to figure out how to relieve those issues that the patient is having. So we've assessed our patient who possibly has constipation. They have a distended stomach, pain, haven't had a bowel movement in about 5 days. and they're now complaining of abdominal pain. So we've got our diagnoses of constipation, acute pain, and next would be our planning phase. So what are we planning to do? How are we planning on getting this patient from being constipated to no longer having any issues with constipation? As you can see, we have pharmacological agents that we can utilize. Laxatives will probably be your best bet. You don't want a patient using laxatives all the time. So if someone were to tell you that they use laxatives literally every day to have a bowel movement, then we need to be assessing something further, because can actually do more harm than good on your body. Remember, having a lot of bowel movements, releasing waste, we gotta make sure that we're not depleting our body of certain electrolytes, certain nutrients, etc. So the laxatives is actually what we don't want them to use all the time, but in a episode of constipation, that will be beneficial. You have your antibiotics for a patient as well, but for laxatives, that can be our plan to use for a constipation patient. We then have our implementation phase. So we give the patient the laxative. So last piece in the nursing process will be evaluation. We gave him laxative. Did it work? That's pretty much what you need to be asking yourself. If it's not working, you got to remember that the nursing process has back and forth arrows, meaning you're just going to have to go in between each section to make sure that the appropriate outcomes for your patient have been met. So, okay, the Miralax didn't work. We still have several other laxatives that we can try. So maybe go back to the planning of giving the more faster acting laxative, and then intervening by giving it to them, and then evaluating that the suppository worked. You also have your anti-spasmodics, which will be pretty important for a patient who is going through bladder spasms due to kidney stones, things like that. You have your pain medicine, which obviously is not just including Tylenol. We're talking about possible Norco, morphine, or Dilaudid, because sometimes with constipation or with kidney stones, that pain can get so severe, Tylenol will definitely not work. Antibiotics can be appropriate. Just think about um, some of those conditions like C. diff. They're going to need to be on an antibiotic. We're clearly fighting a bug. The usual antibiotic for C. diff is vancomycin, but the doctors also like to pair it with Flagyl, because they don't always like to treat with just one because of risk for resistance. So you may very well see patients with C. diff on vancomycin and on Flagyl. So that's something good to know as well. Um, in regards to management of incontinence, these are just a couple of recommendations on how you can get your patient to have just a little bit more dignity, because not everyone honestly wants to have an incontinent period. I have definitely met the patients who can care less that they're urinating or having a bowel movement all on themselves. I actually took care of a patient like that about 4 weeks ago. Was told in report that she's incontinent, and I'm like, does she get up? She very well gets up. There was actually a bedside commode by her bed. She just chose not to ring the bell on time because she thought that we were not going to get to her. So very well, I might as well go ahead and have a bowel movement on myself. And this is a woman that definitely had irritable bowel syndrome. So every 30 minutes, she was unfortunately ringing the bell to get to the bedside commode. But I'd rather her do that than to continue to have a bowel movement on herself. And to the point, she was actually beginning to be okay with having a bowel movement on herself, until I said, no, you don't want to lose what you already got. You're still able to ambulate, to get to the restroom, get to the bedside commode. So that's what we're going to do. And that was pretty a good reason to maintain her dignity. Skincare is obviously a big issue with those who are incontinent, like truly incontinent. You run the risk of skin breakdown, pressure ulcers, and then eventual infection. There's people who definitely died from pressure ulcers that became so bad, so infected. So if we can just start at the beginning where we don't have to worry about these things, then that's what we need to do for our patient. At this time, I'm going to go ahead and stop for part 2. There will be a part 3 as we lean towards urinary and surgical procedures, and we're going to be ending in part 3. Thank you.